And cortisol itself can inhibit TSH. So, the sex hormones can definitely be affected, but even thyroid can be affected by chronically high cortisol levels.
You're listening to the Ethos Athletes Podcast, where we believe that your health is the number one resource you need to accomplish your dreams. My name is Dr. Matthew Hernandez, and I'm a physician dedicated to helping my patients maintain their active lifestyle and continue doing what they love. I'm sitting down with other experts so that we can provide our listeners with the knowledge they need to improve their health and live their best life. Hey everyone, this is Dr. Matthew Hernandez, and you're listening to the Ethos Athletes Podcast, where we provide resources to help you stay active and healthy. Today, we're going to be continuing our performance optimization series, where we're talking about some things that you can do to really optimize your body and just have it perform better. For this series, we have brought on Dr. Warren Brown, who is the owner of Clinical Advances for Sport here in Scottsdale. And this is one of the things that he specializes in is performance optimization. So Dr. Warren, welcome back to the show.
Thanks, Dr. Matt. It's great to be back. Always a pleasure to speak with you.
For those of you who have missed the last few episodes, we've discussed in the first episode of the series, we kind of discussed the big picture overview of some of the factors that go into performance optimization. And then from there, each episode after that, we've broken down each of those factors and gone into detail about them. So the very first one has to do with gut function. The last episode was on energy production, where we discussed the importance of mitochondria, how to test to make sure that they're healthy, and then what we can do to help improve them. And then today we're going to be talking about cell signaling and hormones. So Dr. Warren, why don't you go ahead and talk to us a little bit more about the cell signaling and hormones and why it's important for athletes?
Yeah, hormones, well, I call it cell signaling because the hormones really are basically chemical messengers that the body makes to tell other cells in the body what to do. And in some cases, these signals are going to other parts of the body that are giving up signals that are ultimately telling a target tissue how to behave and how to respond. So they really kind of govern pretty much everything in the body. So it's I call it signaling just because they are chemical messengers, or hormones are chemical messengers. And I think everything from the adrenals to the thyroid to the sex hormones are all going to, in some ways, work together and ultimately dictate how well or how balanced those hormones are in the body. And that's especially true for athletes. My approach to hormones is always adrenals, thyroid, and then the sex hormones in that order. And there are some nuances there that I'm sure we'll get into in a moment, but they can impact each other. So I tend to start with the adrenals, and that is an organ that a lot of athletes have overtaxed and pushed too hard. And so there's good news is there are some things we can do about that to help with that.
Yeah, so you mentioned the big three of adrenal, thyroid, and sex hormones. And what I like about this particular, about your particular approach is that it's very comprehensive in the fact that it looks at those three. There's a lot of hormone clinics that exist out there that, like on the men's side, they just push testosterone, and they may look at thyroid, but it's rare that they ever look at the adrenal gland and the hormones that are produced from that. My experience has been very much like yours, where if you go and have an issue, like if you have low testosterone, there's almost always going to be an issue with the adrenals as well. And so if you don't work to correct that, you're always going to be giving a subpar treatment to the patient, and that they're always going to, they're in general just going to feel subpar because they're going to feel like they're not 100%, like something's just quite not right. And it's usually the case until you address adrenals and thyroid as well, assuming that they need to be addressed. Mm-hmm. And so that's what I really like about your approach, and that you do take all three into consideration.
Yeah, you're exactly right. And a lot of times, those folks who go to the low T clinics and get replaced, they may feel better for a couple of months, but then all of a sudden it's not working anymore, and they think, oh well, I need more. More. It's really because they haven't addressed the foundation, and that's the adrenals and the thyroid.
Yeah, absolutely. And so I like how you prioritize it all, because even when I go and I discuss this with my patients, I kind of draw them out in a triangle and I explain, okay, they're all connected, and you need to understand that your symptoms could be from one being out of balance, or maybe even all three being out of balance, or a combination, any combination between that. So our job is to kind of figure out what that combination is, and then go from there.
Right.
Let's talk a little bit about the first one, which is just the adrenal gland. Can you tell us a little bit about why it's important? What are the hormones that are produced by it? And then I'll ask you a few questions after that.
Sure. Yeah, the adrenals are basically our adrenals are making cortisol, which is kind of like a get up and go to work type of hormone, and DHEA, which is sort of a growth and repair kind of hormone. So our adrenals can make both. That's in the cortex. Of course, they also make epinephrine and norepinephrine, which is part of the story too. But I tend to see more problems with cortisol. And I think that's because for a lot of athletes and a lot of people in general, if we have chronic stress, we're pumping out cortisol chronically on a chronic basis, and it wasn't really intended for the body to do that. So we start to see the quote unquote adrenal fatigue over time. So basically, it's just making cortisol on a chronic basis. So I think, and then of course, there's aspects of overtraining where we can see more adrenal dysfunction as well. So marathon runners and ultra marathon runners, they're really pushing their bodies really hard, and it seems like pumping out a lot of cortisol and for a long period of time. So the problems with that, having high cortisol, is that we tend to hold on to weight around the middle. That can lead to sleep disturbances. We can be more catabolic. We can lose muscle mass more quickly. We can be irritable. There's all kinds of symptoms associated with cortisol excess. And I think the connection there between cortisol and the other sex hormones is because if we're chronically stressed, we're going to make cortisol at the expense of testosterone and estrogens. So it's that notion of the pregnenolone steal, where the body will sort of funnel the hormones towards cortisol production and away from testosterone and estrogens.
Yeah, I really like that explanation, because I have a lot of people, or a lot of men who come into my office that experience some of the symptoms of low testosterone. And when you go and you find out, okay, they're under chronic stress because of their job, family, different things like that, just the amount of responsibility that they have. They want to know, why am I not making as much testosterone as I should be, different things like that. And I think what you mentioned, that pregnenolone steal, is really important to go and actually talk to them about. Of they're having higher levels of cortisol, and that's basically taking away from their testosterone production, because it all falls on a very similar pathway of hormone pathway of, you essentially start with cholesterol, and from there cholesterol gets turned into a bunch of different hormones, and based on what your body needs is where it shunts that production to.
Right.
So yeah, I like the fact that you brought that up, the pregnenolone steal.
And also, sort of following on those same lines is cortisol, and some of the hormones that are involved in cortisol production can inhibit thyroid function. So corticotropin releasing hormone can inhibit TSH, and cortisol itself can inhibit TSH. So there can be impacts with thyroid as well. So even the sex hormones can definitely be affected, but even thyroid can be affected by chronically high cortisol levels.
Yeah, absolutely. You use the term adrenal fatigue, which a lot of people have probably heard of. They might have some idea, but then others, may have just heard it, not know anything, not know what it means. Can you explain a little bit about the process of adrenal fatigue, how it starts, what the end result is, all that stuff?
Yeah, adrenal fatigue is it's not a term that I typically don't use that term, but a lot of my patients do. So it's medically, the term has been it's controversial. So I typically say adrenal hypocortisolism, or HPA axis dysfunction is really more medically correct to say, typically in that context of quote unquote adrenal fatigue. But what I think what leads to it ultimately is that today in most of our lives, most of the people listening to this and most of the people who I see, is that we're faced with chronic stress. And we have all kinds of different reasons why we're faced with chronic stress, whether that's family stresses or work stresses or I mean, just any number of different things. But that chronic stress means we're just chronically making cortisol, and it's a gland. And the adrenals are glands. They sit on top of the kidneys, but they are glands, and glandular function can wear out over time. If we lived long enough, we would probably see other glands in the body start to decline. At some point, there's just a finite amount of function there. At least that's what we think currently. But I think chronic stress over a long period of time is probably the biggest reason why we start to see this adrenal, quote unquote, adrenal fatigue. And I think it's just because there's so many factors in our society that sort of contribute to that. But also, I think overtraining, and with the context of athletes, overtraining is probably one of those factors that contributes to it.
No, that's good. So essentially, adrenal fatigue is hypocortisolism, meaning there's low cortisol production. And so like what you said, essentially is that you are under this chronic amount of stress, you're producing excess cortisol constantly, and then eventually you start to wear out, that cortisol production decreases, and then you can go into this state where you're just not producing enough, correct?
Yes, you're exactly right. And there are stages of adrenal dysfunction too that Hans Selye sort of put this theory together about stage 1, stage 2, and stage 3 adrenal dysfunction, where initially cortisol levels are high. And if over time they remain that way, they'll start to fall because the gland will, fatigue, so to speak. And then, that's in the first stage. The second stage, that DHEA starts to fall as well, which is also produced by the adrenals. And in the third stage, we see that they're both kind of flat, DHEA and cortisol. So I typically don't. I think that's a good theoretical construct for approaching adrenal dysfunction, but a lot of times there's probably some gray area in between stages.
Absolutely.
It's a really fascinating gland.
I just want to make this point too. There is a stigma that a lot of people have around cortisol and how it's, it's quote unquote a stress hormone, and people associate stress as being bad. And so they assume that cortisol is bad because of what it can do when it's elevated all the time, which is what you said. Like there's sleep issues. You can go into catabolism. There's a lot of weight gain around the midsection, irritability. Cortisol is actually the hormone, or one of the main hormones that's responsible for waking you up in the morning. And so I kind of want to clear up a little bit shed a little bit of like light that cortisol is in fact a good hormone that is essential for you to function. And it's because it's part of what wakes you up in the morning. It's its highest concentration in the morning, and then it tapers off throughout the night. And it has this inverse relationship with melatonin, which is low in the morning, high at night. And that's what helps you go to sleep. In medicine, we look at like cortisol rhythms, where you should have your highest cortisol throughout the day, and then it tapers off at night. And someone that's having maybe like a sleep disturbance, their cortisol could be high in the morning. It decreases throughout the day the way it's supposed to, and then right before they go to bed, it starts to spike, and that's causing them to have issues with sleep. Or you could just follow the same curve, not produce enough, and then you're just tired all the time. So there's a few different ways that cortisol, can show up, or issues with cortisol can show up. But in general, cortisol, when it's balanced properly, is a very good hormone for you.
Right. Exactly.
Yeah. I just wanted to clear some of that up, because I've had patients come in with, I want cortisol to be low, correct? Like, no, not necessarily. You want it to be normal. And so this is what normal looks like. Speaking of which, is there, when you're looking at, what cortisol should look like, are there any kinds of testing that you do, and then if there is testing that you do for adrenal gland or for the adrenal gland, what are some of the ideal ranges that we want to see people at?
One of the best tests for adrenal function is salivary cortisol levels, because they are able to, we're able to do it multiple times per day. And so we're able to see the diurnal rhythm of cortisol. And exactly like you said, we want to see it high and nice and robust in the morning. And we want to see that decrease throughout the day. So salivary cortisol testing is kind of the way to go to assess it. It's been around for, maybe 40 years or more, maybe, in published literature. So it's pretty well validated, and it's really useful. Salivary cortisol testing for that. I don't recall the specific ranges, that like the specific range for each pattern through the day, but they're usually, if depending on which lab you go with, there's usually well plotted out into a graph that helps show the ranges. For you can also measure DHEA and saliva at the same time, so you can kind of get that sense of, is this patient more catabolic? Are they making more cortisol than they are DHEA, which is more of an anabolic hormone? So you can kind of see some balance. So the good tests out there will look at both. So saliva is kind of the way to go, because you can get those multiple specimens through the day. Some conventional providers will look at cortisol. They typically do it first thing in the morning through blood, but it does, if we're just getting 1 point in the day, we don't know what cortisol looks like through the rest of the day. And cortisol is dynamic, and it does have a rhythm. So we need to look at it through the day. So I don't do a lot of serum cortisol testing, but I do quite a bit of saliva cortisol testing.
One of the controversies behind doing cortisol testing in general is that cortisol production is reactive based on a given situation. So like the example that can be used is, let's say you're going and you're going to be doing, whether it's a morning blood draw or a salivary cortisol test, when you go and maybe like a few minutes before you're about to go and like do the test, you're driving and you almost get in an accident, and that causes your cortisol level to spike.
Yeah.
So then now, how accurate does that test become? So some people argue that, I guess one, like we should answer that question: how accurate does that test become? And then two, some people or some other doctors will argue that ACTH should also be tested. And so, can you are you able to speak to that test as well?
Yeah, it's a good point. And so for some patients, just having their blood drawn amps them up. They sort of anticipate the pain that creates some stress. So is that serum cortisol with the blood draw, is that going to be real accurate? And I would say that's one of the big problems. If you're about to get stabbed with a sharp object, your levels of cortisol are going to be a little higher typically.
Yeah.
The second part of that question about ACTH, I think there is a place for that, but usually with the ACTH testing and looking at cortisol from that lens, it's more trying to rule out adrenal pathology, like Cushing's or adrenal diseases, and it's just a little bit different context from the context that I look at it from.
Absolutely, and that's been my experience as well. Is you can run an ACTH and on someone that has low levels of cortisol production, and the ACTH is going to can come back normal because they don't have a quote unquote like serious adrenal pathology like a tumor or something like that.
Right.
But they're still experiencing the symptoms of what having low adrenal or low cortisol production can cause. So that's kind of like an interpretive. You have to look at how to interpret that essentially, and that's kind of where our expertise comes in.
Yeah, and that has a place. I mean, if somebody does have a tumor, we need to figure that out. And,
absolutely, yeah, that's kind of important.
I think there is a place for that, but it's just a little bit different context from what we're typically seeing in practice day to day.
Yeah, absolutely. So let's say someone is experiencing low levels of cortisol production, or they're experiencing excess cortisol production. In general, because obviously everything's going to be individualized based on a number of other factors. In general, what are some of the things that you're doing to help someone with this issue?
Yeah, adrenal adaptogens are a core part of my plan. Lifestyle is a core part of my plan. Those two tend to really help restore dysfunctional cortisol, adrenal function. So adrenal adaptogens like ashwagandha tends to be a really good balancer. Magnolia, rhodiola, there's a huge list of them, fortunately. And some of them work better for certain patients. You probably found that as well. There's
Absolutely.
somebody that might respond a little better to rhodiola. Another patient might respond a little better to ashwagandha, but they tend to balance adrenal function. So I think about those in particular if I'm seeing cortisol levels high. The lifestyle aspect of what I was mentioning a moment ago is things like stress management practices, whatever that looks like for the patient, whatever they're willing to do to help calm themselves a bit. So whether that's breathing exercises or yoga or something like that. I've seen some patients who are the only kind of physical activity they're doing is high intensity interval training, and they're just really hitting it hard and their cortisol levels are high. And I'm like, well, maybe you shouldn't do that 7 days a week. Maybe you should, do a couple days a week, do yoga instead to try and ground yourself a little bit more. And so sometimes it's just tweaking their routine a bit. So yeah, the lifestyle aspect piece is huge for high cortisol levels and adrenal adaptogens as well. And there are some adaptogens that can help with low cortisol levels, like licorice root, which can double the half-life of cortisol. So if you're seeing a patient who's in that stage 3 adrenal dysfunction where they were just really flatlined for cortisol, then sometimes they need a little bit, as you were mentioning earlier. And things like licorice root, or some clinicians use glandulars for that, adrenal glandulars. That can help with low cortisol levels. But most of the time when I'm seeing them, they're really high cortisol levels.
And that makes sense. I like how you have a funny story of a patient that falls along the lines of what you just mentioned, where they're doing HIIT training. It's actually not my patient; it's my partner's patient. But they're doing HIIT training 7 days a week, and they're unable to lose weight. They're irritable. They have sleep issues. Their mind's always racing. They can't go to sleep at night. They're a business owner. They're kind of like high-powered individual in general, and she's having all these issues. And she goes and says, "Okay, well, and my partner goes and says, well, you can't be doing HIIT training 7 days a week." And I think she was doing Orange Theory, if I'm not mistaken. Anyway, you can't be doing HIIT training 7 days a week. You're increasing your cortisol levels like that. That's what's causing all your issues. Like, I can't help you unless you make that change. And her response was, well, my chiropractor says that me working out is my stress relief. So it's what helps me with reducing stress. It's like, well, yeah, but your chiropractor doesn't know anything about your hormones. I do. So you need to stop, because ultimately you need the stress relief, but you need to find another way to do it, because that's just decrease the frequency. I'm not telling you to stop Orange Theory, but you need to decrease the frequency at which you're doing it.
Yeah, it's a good point. It's a really good point. Sounds exactly like we've seen that same type of patient. So yeah, I think there is, and naturally the body works better with variation. It's one of the reasons why we don't train every day doing the same thing over and over. So it makes perfect sense.
For sure. When we're looking at, again, last thing on cortisol, when we're looking at cortisol treatments, there's some doctors that go and prescribe low doses of hydrocortisone, like oral hydrocortisone, that you take throughout the day to kind of give you, it's like a physiologic dosing of hydrocortisone to replace your cortisol production. Have you seen that, and can you speak to that therapy at all?
Yeah, it makes sense if cortisol levels are just flatlined
right
the day, then that patient will need some help. Usually that's a very sick patient who's just has been burning the candle at both ends for their entire life, typically. So I've never had to go to that point before, but it makes sense, at least theoretically, that would help. The trick is not to overdo it, because if we overdo it, then that patient is going to eventually develop blood sugar issues or any of the symptoms of cortisol excess.
Yeah, for sure. Cool. I think we touched on cortisol quite a bit, and adrenal function in general. Let's move over to thyroid. Tell us a little bit about. I feel like thyroid's one that a lot of people know a decent amount about, but let's discuss some of the thyroid hormones and some of the patterns that we can see when we're looking at issues with thyroid hormone.
Yeah, you had a nice summary of thyroid function, and that's exactly how I think of it in that last episode. And you were talking about TSH, thyroid stimulating hormone, and how that leads to the production of ultimately T4 and T3, which are different thyroid hormones. And you even mentioned reverse T3, which is important to look at too, because if we're just looking at total T3, we don't know how much of it is in the reverse or inactive form,
right?
And how much of it is in the active usable form. So it sounds to me like you're looking at a lot of the same things that I look at when it comes to thyroid function. What we didn't touch on last time was some of the nutrient cofactors that are involved in thyroid function, and I think those are often forgotten about. So things like selenium and zinc, vitamin A, even some of the B vitamins, vitamin C and vitamin D, all play some role in that conversion or building of thyroid hormone. And some have more to do with the sensitivity of that thyroid hormone on the cell receptor. So I think that is often overlooked too. So it's another reason why I think nutrient support can sometimes help thyroid function. But we were also talking about cortisol and corticotropin releasing hormone and their impacts on thyroid. That's generally kind of the most prominent relationship I see between adrenals and thyroid.
Can you repeat that last part again?
Sure. The corticotropin releasing hormone can inhibit TSH, and TSH is thyroid stimulating hormone that gives the signal to the thyroid to make thyroid hormone. So, and it can be inhibited by corticotropin releasing hormone, which is part of it's involved in the pathway that produces cortisol.
I know I did it on the last episode, but let's walk through the pathway of thyroid hormone starting from TSH and then kind of discuss different things that can happen at each given point. And the purpose of this is just because I want to illustrate why just running TSH isn't always enough. So if you can kind of discuss that and walk us through that piece of what you look for.
Yeah. TSH is thyroid stimulating hormone. So that gives the signal to the thyroid to make T4, and that can ultimately convert into T3. And TSH we get the signal to produce TSH from the pituitary. And ultimately that comes from even higher up in the brain, in the hypothalamus. So there's quite a few steps there. A lot of conventional providers will just look at TSH, and if TSH is normal, then they'll say, well, you're probably making enough thyroid hormone, and they'll sort of stop there. Sometimes they'll look at T4, sometimes even T3, but it just seems pretty rare, and often it's just looking at TSH and saying, okay, that's good, you're fine. But that's only part of the story. And because thyroid hormone really dictates our metabolism for pretty much every cell, it does have a big impact. So yeah, I think just looking at TSH alone is probably going to be a little short-sighted.
When we're looking at the hormone or the T3, T4 in general, there's total T3, there's free T3, there's a free T4, total T4. Is there any one that you find more useful than the other? And what's the difference between them?
Yeah, and we're probably on the same page with this too. I like to look at free T4 and free T3 and reverse T3 because they all do different. They're all total T4 could be bound to binding hormones, and therefore it might not be usable unless we're looking at the free form. The free form really correlates much better with what a patient might feel symptom-wise. Same thing with T3. Free T3 is going to tell us more than total T3. And if we're just looking at total T3, we can't tell how much of it is in the reverse form or the active form. And so there's some biochemistry related to that with essentially that talks about the shape of the hormone. If it doesn't have the right shape, it's not as usable. So uh, I like to look at free T3 and reverse T3 so I can get a sense of, if their total T3 is okay, but how much of that is actually usable to them. And that's why I tend to look at the free form, free T3.
Yeah, that's a good point. And just to kind of explain, a lot of people have probably heard of T3, T4. T4 is the hormone that your thyroid gland makes. T3 when it's free, is the active form that binds to a given cell to like do cell signaling and do what the thyroid hormone tells it to do. We've mentioned reverse T3. This is something that I don't know of any conventional doctor that runs this. I haven't seen it on a lab report yet from a conventional doctor, but it's something that we run in our practice, and you obviously run as well. When you have T4 gets converted to T3, and so it'll get converted to T3, and then it could also get converted to reverse T3. Both of these molecules are very similar, and they both bind to the same receptor on a given cell. So if you have a lot more, you basically want to look at the ratio between the two, because if you have a lot more reverse T3, it's going to bind to the same cell or to the same receptor as the cell that your free T3 will do, except reverse T3 is an inactive form, doesn't do anything. So it's out competing free T3 for that receptor when the ratio is more in favor of reverse T3. And you're not getting the benefit of the thyroid hormone that you should be getting, and that's called like subcellular hypothyroidism. Unfortunately, in medicine, most doctors just look for TSH, and TSH is directly your level of TSH is directly impacted by the amount of T4 that you produce. So if you end up having subcellular hypothyroidism, you can have a normal T4, but and a normal TSH, but you're still experiencing symptoms of not having enough thyroid hormone, and a lot of doctors miss that when they look at those levels, because they don't check again free T4, free T3, and then it's rare that I see someone that actually checks reverse T3, and so it's important to know, because the patient could be experiencing, they could do research and say, oh, I have all the symptoms of hypothyroidism, but my doctor says I'm fine because my TSH is normal. Yeah, and we see this a lot in our practice, where like they're just kind of made to think that they're crazy, and then we come in and do this test, and it's like, oh, this was actually the issue. And so you did have hypothyroidism. It wasn't detectable with the tests that were run in the past.
Yeah, it's a good point.
What are some of the things, we're looking at performance optimization. What are some of the things that a athlete and just a person in general can experience if they have issues with thyroid hormone?
It could impact, their body composition, of course, because if we've got a sluggish thyroid, or we're making an active thyroid hormone, generally it's going to be harder for us to metabolize things. So yeah, I'd say body composition. They might hold on to fat a little bit more. They might feel sluggish. That's probably the most common scenarios, that they'll feel like they don't have that same level of energy that they once had. So, I mean, thyroid touches on pretty much every living cell. So it is really important. It does dictate our metabolism.
And that, I think that's the most important thing that people attribute it to, is like that they have issues with weight gain, fatigue. They might have like heat and cold intolerances, stuff like that.
Yeah.
Talking about like some treatments and stuff like that. What if you have someone that typically you're going to see in our practice, where you're going to see people that have low thyroid hormone? I would imagine yours is going to be the same. What are some things that you do for treatment outside? Is there anything outside of just medication?
Yeah, medication definitely has a place. So taking thyroid hormone can really make a big difference for some people, and for some people it's absolutely necessary. So I'm not against thyroid hormone. There are some glandular options too that might have, they're extracted from thyroid of animals basically, and they'll have different ratios of T4 and T3 to them, which is a good option for some people. So, and then, with the medications, there's T4 or T3 that you can prescribe. So it's more common for people to be prescribed T4 with the thought that they should be able to convert it into T3. So there are some options for manipulating it directly, but some of the nutrient cofactors involved in thyroid production, I think, are always worth trying to uncover as well. And that's where some of the vitamins we mentioned earlier can be helpful. But yeah, I think a combination of nutrient support and in some cases thyroid hormone support can be helpful. And then the stress can also impact thyroid function. So I think that needs to be taken into account if you're addressing the thyroid. There is a stress component for some people that needs to be addressed as part of the treatment plan.
And then, as you mentioned, also like going in and treating the adrenal gland, if there is adrenal dysfunction, can actually go and help improve thyroid function as well, without even giving any kind of thyroid medication, stuff like that.
Right.
Let's chat a little bit about sex hormones now. And when we're talking about sex hormones, we're primarily talking about estrogen, testosterone, progesterone, different things like that. Let's go into what hormones you look at specifically, in addition to what are some of the patterns that you can see as issues with this, and we can discuss men and women if you're able to speak to both of those.
Yeah. So there are some some patients who, when they get older, they'll start to see this decline in the production of the sex hormones, and there's a lot of data on menopause, and when the ovaries in menopause start to decline in their production of the sex hormones, we see that. That usually happens somewhere around age 50 or more or less. So menopause is sort of well established. Andropause for guys is a sort of a newer concept, and that is thought of sort of in the same way that that testicular production of these hormones might decline at some point, when we hit our 50s or later. So, and for some guys, it's even sooner. So there is this concept of these hormones starting to decline over time, and that being part of the natural aging process. As far as testing for it, there's a number of different options. You can test hormones in urine and blood or in saliva, and they all have their pros and cons. And I think that it really kind of comes down to what's the clinical question here? What are we trying to address for the patient? Why we might pick a certain specimen type to measure that. And I'd say in patients who are a little bit older, I like the urine tests at some point, because you can get some information on how they're metabolizing their hormones. And that has to do, there's some metabolites, things like metabolites of estrogen, that can give us a little bit of insight into disease risk. Certain types of estrogen metabolites, like the 4-hydroxyestrogens, they have associations with breast cancer. They have associations with prostate cancer. So they can be useful to test in men and women, and that can only be done in the urine. So I may use a urine profile if I'm trying to get more information about that. In blood, there's a lot of data, a lot of published literature on measuring hormones in blood. There's some debate on whether or not, if we're supplementing with hormones, how effective that can be in terms of detecting them. So there's not really a clear answer there. Some say that they're underrepresented in blood, but I think there's some nuances to interpreting them that need to be taken into account there. In saliva, generally, we're measuring free, unbound, bioavailable levels, and that's one of the biggest benefits of measuring in saliva. So I use all three. I use all three specimen types. I think they all, they answer somewhat different questions, and they can be useful for getting insight into the health of the patient. And that applies for young and old patients. I think I generally don't measure hormones, the sex hormones, in people under 18, just because it's hard to extrapolate those reference ranges. But in adult patients, any adult patient, I think all three specimen types have merit to them. Did that answer your question? I kind of went on a tangent there.
No, you're good. No worries. Yeah, you answered what I was asking. When we're looking at, so let's take a look at women. What are some of the hormones that are important to them? And then let's start with that. What are some of the hormones that are important in women's health when it comes to performance optimization?
Yeah, so estrogen and progesterone in premenopausal women and testosterone are really kind of the big three sex hormones that some premenopausal women have to achieve balance and in order to really be truly healthy. So those are ones that I look at, and when you're looking at estrogen and progesterone, estradiol and progesterone in a cycling female patient, I like to look at them in the luteal phase, which is somewhere between day 19 and 25. That way you can sort of see that luteal spike because there is some rhythm to those hormones throughout the cycle. So I like to look at them in the luteal phase, and that will sort of give me a sense of how high, did they hit that spike that they need to hit for progesterone. So you can also track those throughout the cycle. If you look at them in saliva, you can look at those hormones throughout the cycle. Sometimes that can be really helpful too. If you've got a patient with a really dysfunctional cycle. In men, they're pretty straightforward. So I tend to they can test hormones at any point, but if they're having symptoms like hormone related symptoms, sometimes I'll tell them to collect their specimen on the day when they're just feeling most symptomatic. Sometimes that can be helpful. Let's see here. Yeah, and I think often what I see in patients as they get older is that their hormones tend to be a little bit lower, which sort of fits with what we know about that physiologically. But a lot of times when women are around menopause, if they have a lot of aches and pains and arthralgias, then I will look at not only their estrogens, but also their testosterone and their DHEA, because often they're really low in DHEA and testosterone. And if we run into that scenario, then it's going to be harder for us to heal. So if they have a lot of muscle pain and arthralgias, then I'll make sure to look at those and see if they need any help there.
Okay. When we're looking at sticking with some of the like women and women's hormones, and I may be going outside a little bit outside your specialty for this at this point, but if I am, let me know. Are there any special considerations when we're looking at training in women, when in cycling women, I should say, with different considerations that we might have during a certain phase in their cycle?
Yeah, there are some, like for instance, like women who develop amenorrhea where they're just not cycling because they're training so hard. Is that the question?
Yeah, so you can talk about that a bit, and then also just if there's any changes that should be made in their training based on their cycle as well. Like if they're in luteal phase, they should be focusing more on this type of training versus if they were in the other phase, stuff like that.
Yeah, that's a good point. I think I always tell my patients to listen to their body. So if they're just feeling really like in the first part of their cycle, if they're feeling really just sluggish or if they're just not feeling well, to listen to their body and do a rest day if there's a particular part of the cycle that's problematic for them. I also think back to the impact of cortisol on the sex hormones and that concept of the pregnenolone steal, because if they're carrying a lot of stress, if they're overtraining, then that can come at the expense of some of the androgens and estrogens.
That makes complete sense, which would then impact their, how they recover, if they're able to build strength, all that stuff, I would imagine.
Right. When
we're looking at men, obviously the biggest hormone that revolves around men is testosterone. If that, what those levels look like when it comes to performance and optimization. In your experience, what are some of the things that can contribute to men having lower testosterone, and how do we go about addressing that?
Yeah, I think a lot of times it's stress related. So the adrenals have a lot to do with that, similar to what we're talking about with the pregnenolone steal. So I think that is the case for, I would even say, most of the patients that I see, is that there's an adrenal issue why they're not making more hormones. But I think there are some factors like environmental toxicity or excess aromatase activity, where they might be taking their testosterone and hyper converting it into estrogen for whatever reason. There's things that can upregulate that aromatase pathway. So sometimes we see that with things like alcohol use, or if they're carrying a lot more adipose tissue, they can aromatize their testosterone into estrogen. So their testosterone can actually look low and their estrogens can look a little high. So I think I've seen that to some degree. But I'd say for most of my patients, it seems like there's a stress component to why their testosterone is not higher.
That's typically what I see as well. What do you? So obviously, you go back to step one of treating the adrenals. Are there any other recommendations that you give to these people, to these individuals?
I mean, for some patients, testosterone replacement therapy can be warranted, but of course, we can't do that, or DHEA if we've got somebody who's in competition, if that's a banned substance for them.
Right.
We can't use those, but there are. That's one of the beautiful aspects of treating the adrenals, is that this is something that's nutritive to the adrenals. That's really, it's something that's and especially the lifestyle aspects of it. This is something that's safe for everyone to do.
Yeah, absolutely. And you can make a huge impact just doing that itself. Awesome. I think we covered a lot on cell signaling and hormones. And I like that we went into a lot of depth with the adrenals, because that's one I think a lot of people miss and is super important, as we discussed, because it can impact thyroid hormone. It can impact your sex hormones as well.
Yeah.
Dr. Warren, is there anything else that you want to add to the show and leave our listeners with?
I just want to thank you again for having me, and I always enjoy our conversations.
Awesome. Perfect. We'll go ahead and wrap this episode up. In our next episode, we will be continuing our performance optimization series with Dr. Warren, and we're going to be discussing detoxification as the next one. Is there anything that you can, just like a brief synopsis of what detoxification is?
Sure. Yeah, detoxification. For athletes, I see that one of the primary things that they need to quote unquote detox from is oxidative stress. So getting that balance of making sure that they have enough antioxidants to deal with the oxidants, and so the redox balance, as it's sometimes called. So I think that's a primary issue that I'm concerned with dealing with detoxification, is oxidative stress, which we'll talk about a little bit more. Also, some patients do have heavy metals, things like that can sort of interfere with some of the biochemical pathways that we've been talking about. So we'll touch on that idea as well.
Awesome. Perfect. Then yeah, we'll definitely get into both of those things on the next episode. Once again, Dr. Warren, thank you so much for being on our podcast.
Thanks, Dr. Matt.
And hope you all enjoyed the show, and we'll catch you on the next episode.